and welcome to the Dr. Bob Show. Do you have reflux? Does everybody have reflux? Everybody that I talk to in my practice, when you ask them the question, they've got reflux. Where does reflux come from? Is it dangerous? Can it be treated well? Is it difficult to treat? Do lifestyle changes such as eating right and laughing and exercising and getting sleep, does that help? What side of the bed should you sleep on to help people with reflux? Are there complications from reflux, like strictures, like recurrent belching, like making asthma and COPD worse? All of those fit in with the guidance of understanding reflux. My guest is Dr. Raj Narayani. Dr. Narayani has been on the Dr. Bob Show before. He's one of our best educated guests. And he'll be telling us about GERD, how to treat it, how to improve it, what medicines to use. Are the medicines safe? Do you have to see a doctor? Should you have a scope to see what's going on? A million questions. It's going to be a show that both you and I are going to love. I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes, and I'll be learning too. So you'll want to stay tuned to this show and have a good time. We're talking with Dr. Raj Narayani, board-certified gastroenterologist, stomach specialist, and we're going to be talking about reflux and GERD. Raj, welcome to the Dr. Bob Show.
Thanks for having me again, Bob.
What is reflux, and where does it come from?
So reflux is the action of acid content in the stomach and other substances in the stomach coming up into the esophagus, which lays in the chest above the diaphragm. And that can happen for a variety of different reasons.
The stomach usually acid?
Acid, protein, food content, a lot of things mix in there because the stomach basically digests that food and grinds it and gets it ready for the small bowel.
So normally when we swallow, the food goes down the stomach and usually it stays there.
That's correct.
What makes it reflux?
So if somebody has a stomach that's been overfilled because they've overeaten, if they have had difficulty with chemical substances that potentially affect the valve at the bottom of the esophagus, which is called the sphincter muscle, that could come from nicotine use, caffeine intake. If they have a hiatal hernia, which is an anatomic change in the area where the esophagus and the stomach join together, it happens to converge right at the diaphragm, but if that's disrupted and some of the stomach moves up into the chest, then you can have a hernia which disrupts that valve as well.
So the diaphragm is right below the chest, so I take the area we're talking about is right at the bottom, or right where the diaphragm is, which is very, very prone to getting pressure in the belly that pushes the food up to the throat.
That's correct, yeah.
What kind of symptoms does it give?
So people with reflux or gastroesophageal reflux disease, where it happens frequently and is classified as a condition, often complain of symptoms like heartburn or a burning sensation underneath the sternum.
Isn't that scary?
It can be, especially if it's associated with more intense chest discomfort, because it can sometimes be confusing for heart pain as well. And then sometimes people will complain of a sensation that liquid content is coming up the esophagus, maybe into the back of the throat, and that's called regurgitation.
That doesn't taste very good. I think everybody's burped and they get that on the top of their throat and they feel, wow, and they want to drink some water or drink some milk or drink something to make that discomfort go away.
That's correct.
How does the discomfort get relieved if you have reflux that's up in the back of the throat?
So we have some natural ways that we do it. Our body knows that an event has happened and that acid doesn't belong in the esophagus. So you will often hypersalivate, especially if it happens at night while you're laying down, and that saliva will actually run down the length of the esophagus and neutralize the acid content that has come up.
So is the saliva basic to neutralize the acid of the belly?
Correct. It's just basic chemistry again there. That's right. And then your esophagus will actually increase its contractility in order to push the acid back down into the stomach. And some reflux patients who have difficulty with these things, maybe they don't make as much saliva, maybe they don't have very good esophageal motility, will often be the ones prone to more injury from acid reflux in the esophageal lining because the time that acid spends in the esophagus is longer.
So how long does it normally take food to get from the top to the bottom or into the stomach?
So when you're swallowing, the normal mechanism in a healthy esophagus should take about 1.5 seconds or less.
So it normally is real quick.
fast.
And if something slows it down or gets it where it stays in the esophagus, you got that heartburn, that acid indigestion. Are those both used together?
They can be. Indigestion is a little bit more loosely used. It can still be synonymous with acid coming up and producing that heartburn sensation. When you talk about swallowing and having something go slow or delayed or stop or stick, we call that dysphagia, and that can arise as a consequence of reflux as well, because either the contractility of the esophagus doesn't allow the food to go down all the way, or if acid reflux damage has occurred over a lengthy period of time, you can get scar tissue buildup in the esophagus, which may narrow the caliber of the esophagus and prevent solid food from going down.
Is that dangerous?
It can be if the episode is prolonged, and it's one of the most common reasons that a gastroenterologist will be called in the middle of the night, is that we need to sometimes go in and actually remove that food for the patient because it won't clear. But most of the time it will clear if somebody drinks some water or just simply waits some additional time. And as long as it clears, it's no longer dangerous, but strictures need to be evaluated because they can be treated.
So are there common foods that will stick in the middle of the esophagus and give the symptoms of heartburn?
Any food that has a robustness to it, so bread, meat, chicken, things that have substance to them that are hard to break down, and if a person is a little bit sluggish about how much they're chewing their food, then sometimes a larger bolus will get stuck. Sticky rice has been described as a common culprit as well.
So I had some chicken stick in the middle of my esophagus. I knew what it was. I knew it was the chicken. So I called the specialist, and the specialist said, I know what it is. It's not dangerous, but I'm obligated to look down and make sure that I'm not missing anything, because you can't tell unless you look.
That's right.
Chicken is a big offender if I eat too much, too fast, too quick, because I'm hungry. But I have a good feeling that I know if I just wait, in my case, about 20 seconds, it's a long 20 seconds, but the feeling I get is like a pressure, and the same kind that we describe when we ask somebody about who's had a heart attack. What's the pain like? Well, it's a pressure, knotting pain right behind the sternum. So I can see why a lot of times a gastroenterologist would get an emergency call for somebody that EKG looks normal, everything looks normal, but they've got heartburn there. And so you have to go and perform, you have to do an EGD then?
So if we believe there's food stuck and it's producing a problem with the patient continuously salivating and producing saliva, then if our suspicion's high that food is still there, we will usually, even in the middle of the night, go in to try to retrieve that food. And that procedure takes somewhere between 15 and 45 minutes, depending on how impacted that food is at the level of the narrowing. And then sometimes, if it hasn't been there for very long, once we've removed the food and we see the narrowing that's been produced by acid or whatever else is the cause, we can actually stretch it at that time or at a subsequent date.
How do you stretch the esophagus, which is a tube that goes straight down? How do you stretch it?
So we have a mechanism where we can pass a wire through the channel of the scope and leave that wire in place as we take the scope out, and then we have devices that slide over that wire that progressively stretch those narrowings open.
How about that?
Yeah.
What's that procedure called?
Esophageal dilation. Yeah.
Okay, and so how does the patient feel after that? Do they say, boy, I've been having a little bit more than I thought, and now the food really goes down nice and easy?
Yeah, the relief is usually instantaneous. Usually within a day or two, the patients can notice an immediate difference.
So if there is contraction there and frequently there's acid that's around that area of contraction. Do you ever get scarring where the swallowing tube gets narrow and narrow?
Yeah, so if acid comes up, contacts the tissues, and then creates injury or burns, basically, we call that esophagitis. If esophagitis is persistent, ongoing, and acid reflux is frequent, then eventually the body will try to protect itself by forming that circular scar at the location where the inflammation is most intense.
Can that be dangerous?
It can be if you see...
And that's what we're going to be talking about. I love to cut out the guess. It can be. We'll see where it can be and why it can't be and what you do for it and what the treatment is. Who's prone to get these symptoms? Are there certain groups of people that are more prone to getting heartburn, acid indigestion, burning of the esophagus? When we come back, we'll go right on. We're talking with Dr. Raj Narayani, and we've been talking about reflux, GERD. We talked about the food in the stomach, which is acid, comes back up into the esophagus where it causes symptoms, sometimes called heartburn, even acid indigestion, a nodding pain. People think it may be a heart attack. When we look down to see what's going on, sometimes there is knotting, narrowing that's causing the discomfort and pain. And now we're talking about, is that dangerous? Do we need to do a scope? And I flashed over the word EGD too fast. Esophagoduodenostomy. So we're going to look down the throat. Raj, is that dangerous?
It can be if you have frequent reflux, if you have risk factors for really bad reflux, if you're overweight, if you smoke, you can sometimes have enough acid contact to cause some of these injury patterns that we've been talking about, including just erosive or ulcerative inflammation, which is called esophagitis. If that,
so you can really get ulcers down there?
You can, and if that persists, then the healing process, which happens naturally, can begin to form scar tissue, and that scar tissue is called stricturing.
And stricturing, so that's narrows again. Well, what happens if somebody gets a stricture? Can you dilate it up like you said?
Yeah, you can actually dilate it to give relief of swallowing trouble. If that stricturing has been there a long time, then the lining of the tissues in the esophagus below that stricture can sometimes change, and that lining then will sort of mutate itself and form a cellular structure that looks more like the stomach or the intestine, because that's the adaptive response of the body to say, I need to try to withstand this acid injury that keeps happening. And that change is called Barrett's esophagus.
Barrett's esophagus, and so that's where the lining of the esophagus changes to a protective mechanism. But the problem with that, it may protect against the acid, but it may also
lead to cancer, actually, because mutations in the DNA of those cells can sometimes occur imperfectly, and if that happens, then some of those changes can actually begin the process of progression towards cancer, and it takes some time to do it. But
when you look down and you see Barrett's, there's been a change in the lining mucosa. Is it easy to identify?
It is, because it looks a lot like the lining of the stomach. So it actually appears, and this is how it was described way back in the 50s when it was discovered, as the stomach lining crawling up the esophagus. It turns out that when you biopsy it, it doesn't actually look exactly like the stomach. It looks more like the small intestine.
What does it feel like? Or you're pushing against it? Is it harder like cancer? Or we think of cancer as being harder?
It's usually soft if it's not in the process of changing, but if the changes that are occurring that lead towards cancer are already in place, then that tissue can become stiffer, it can become bumpy, and when we start to see those kinds of changes, we're a little bit more aggressive about how we biopsy that tissue to try to arrive at the diagnosis.
So you can take a biopsy when you look down, a little piece that goes to the pathologist who tells you it's good or bad, and we hope that it's good. If somebody has Barrett's esophagitis, can you treat that?
Well, you can treat by treating the reflux that underlies the problem, and if you do that, and the acid reflux medication helps keep the acid out of the esophagus, then that can stabilize that Barrett's, and the patient can sometimes live years, decades with stable Barrett's and no changes. If you have Barrett's that has already begun the process of progressing, and we call that dysplasia, where you've got changes that are beginning to resemble cancer but aren't quite there, we actually have techniques and technologies that will allow us to either strip it out or burn it away so that it can heal back over with normal tissue.
It's been a slow, gradual improvement in almost every field of cancer that we have. And here, precancerous lesion, we've got the same thing going. So to me, if somebody has persistent heartburn, and we'll talk about what we can do to help that over the counter, but there's nothing like seeing the doctor who can see what's really going on. So let's talk about somebody's got heartburn, acid indigestion, it's routine, talks to the doctor says, we're going to put you on some medicines first. What else do you tell the patient? What lifestyle changes can help get rid of or assist or guide toward a normal esophagus?
So if a patient is overweight, weight loss is a big factor regarding the resolution of reflux issues.
Why does somebody with a fat tummy have problems with reflux?
So the theory is that when you have overweightedness and you have excess pressure in the abdominal cavity, then that can sometimes put pressure on the stomach itself and force the acid up. And of course, if you have a disrupted valve, like we talked about a little bit earlier, then that can predispose to that acid going all the way up into the esophagus.
Do we advise people, do we guide people not to overstuff themselves? Because it'll make them feel miserable, but it also could cause some problems.
That's right. If you overeat and you distend your stomach, there's a reflexive action from gastric or stomach distension that promotes weakening, temporary weakening of that sphincter muscle at the bottom of the esophagus. So just simply overeating can promote, especially if you lay down, the tendency for some of that food material and the materials it mixes with to come up into the esophagus.
So I take it if you stuff yourself and you lay down, that the pressure of gravity on the belly pushes, and the path of least resistance is back from which it came, which is the esophagus, and causes problems. So weight loss, what else?
So if a patient's smoking, we talked a little earlier about nicotine, and nicotine has a chemical effect of loosening that sphincter muscle tone as well, and it will happen at the most inopportune moments. So if a person's able to quit smoking, that helps. If they're consuming a lot of caffeine, same chemical effect. They need to lessen their coffee or their soda intake.
So that's a joy in the life of some people. Is it hard to get rid of those things? Hard to stop smoking? Hard to stop eating? Yes, but it's important if they want to stay alive.
That's for sure, yeah. If they want to stop the reflux tendency and restore their nighttime sleep sometimes, because some of these reflux episodes will wake you up in the middle of the night and they can be disruptive.
So nocturnal, nighttime GERD, is that common?
It is very common. In fact, if you look across the population, the prevalence of reflux disease is about 10 to 20%. And in that subpopulation, the incidence of nighttime reflux is about 50%.
So it's very, very significant. How do you treat that nighttime reflux?
So there are a few ways. One, of course, is medication, and the timing of your medication can sometimes influence whether you have nighttime reflux or not. The other thing that you can do is elevate the head of your bed, which is something we've been telling people for years and years to do with reflux. That can be done by either putting
If
cinder
you
blocks.
elevated the head of my bed, I'd slide down. It'd be like a slide in a swimming pool. How do you do that? How high do you elevate the head of the bed? What do you elevate it with?
So you can use bricks or blocks if you wish. The estimated distance that helps the most is about 4 to 6 inches to get the headboard up. The other thing that you can do is go to a surgical supply store and you can buy a foam wedge that you can slide underneath the head of your mattress, and that will just simply elevate your mattress. As you know, a lot of beds these days can incline anyways, and so you can use an incline bed if that's something you have in your home.
I've always wanted to have one of those incline beds that would just be snazzy. But I probably would, I go to sleep so easy. A doctor once told me, we're trained to sleep because we're up all night and we're up doing things, and so when we lay down in bed, the reflex says, go to sleep, big boy. Are there lifestyle changes that help? We've got medications, we've got weight loss, we've got elevation of the head of the bed. What else?
So avoidance of late night eating, and most experts would suggest that you should have at least 3 to 4 hours between your last food intake of the day and the time that you lay down to go to sleep.
Wow, I'm a bad patient because I raid the refrigerator at 9 o'clock when I should be getting ready to go to bed. The complications that make people have GERD, it just takes time to teach. You get pamphlets guiding them through that. We've talked about the seriousness of GERD. What other serious complications are there of GERD? We talked about Barrett's.
So if Barrett's has been present for a long time, the incidence of esophageal cancer from Barrett's, which can occur, is thought to be about 0.25% per year. So I like to tell my patients that if you've had known Barrett's for, let's say, 20 years, then your incidence over that 20-year time period is about 5% to develop esophageal cancer. So patients with Barrett's are often plugged into endoscopic surveillance programs, which means every few years we bring them back, we take another look with a scope, we examine their Barrett's area, we look for features that might suggest it's already changing, and even if we don't see them, we still biopsy the surface area of that space in order to get a sampling and have our pathologist look at that tissue.
Going on to other things that reflux can aggravate, asthma, GI bleeding, can those occur?
They can if you have esophagitis.
And that's what we'll be talking about when we come back. It's my favorite part. What great information. And a lot more information to come. You'll want to stay tuned. We're talking with Dr. Raj Narayani, board-certified GI, gastrointestinal physician. We're talking about GERD, reflux. We're talking about heartburn, acid indigestion. We're talking about strictures. We're getting more and more problems that go along with GERD. Are there any problems that GERD, reflux disease, causes in other parts of the body? And we had mentioned asthma, COPD once. What happens with that?
So if there is reflux to a level all the way up at the level of the throat, then you can actually get throat manifestations of reflux, which might manifest as hoarseness or throat clearing. Sometimes you'll feel a sense of a lump in the throat. Some people develop a chronic cough as well.
Yeah.
And then if some of that refluxate goes all the way down into the airway, then you can get asthma, you can get bronchospasm, you can get problems breathing.
Does the reflux cause asthma worsening any other way? I'm thinking of one thing specific.
Yeah, so when acid comes up into the esophagus, because of the proximity of the esophagus to the windpipe, the trachea, you can actually get a reflexive action. It's a neurological reaction, basically, that creates bronchospasm just from acid contacting the lower esophagus as well.
So reflux and reflex can both aggravate that. GI bleeding, is it a common cause of GI bleeding?
It's not a common cause of GI bleeding, but I'll tell you one population where I think you see it a lot more. It's the elderly population who's been hospitalized, who's very sick in the hospital, and they're often, as you know, in a hospital bed laying down. And if they're not on proper acid reflux protection, then they can get really bad esophagitis, and that type of esophagitis can also cause bleeding in the hospital as well.
So now we get worse and worse and worse, and one of the things that I flew over, what type medicines do you give and how do they work?
So we've been lucky over decades of time now because we've stumbled upon medicines that work by decreasing acid production in the stomach. And if you think back to the 80s and early 90s, we used to use products that were called histamine blockers, not like the ones you use in allergy, but a different histamine receptor blocker that actually decreases acid production in the stomach. They were fair, but they weren't great. And then in the early 90s, the proton pump inhibitors were developed.
Proton pump inhibitors, PPIs.
PPIs.
Very common.
Yeah, and of course they're one of the most commonly prescribed categories of medicines in the Western population nowadays. They work better than histamine receptor blockers because they actually act on the outlet of the acid pump in the cells of the stomach lining, and by doing so they actually turn down acid production even better than histamine blockers do. So they've really been the mainstay of acid reflux treatment for a number of years.
How effective are we at treating GERD?
So proton pump inhibitors have achieved success rates that are pretty remarkable for classic traditional GERD symptoms. And around 90% of people are going to say they have at least a significant portion of their symptoms or all of their symptoms suppressed by taking the medication. And there are patients who will break through that, especially the ones you talked about, where they're not necessarily exercising the lifestyle modifications that they need to do or losing the weight, and they might need to have their dose of their proton pump inhibitor increased, let's say from once a day to twice a day, or combination proton pump inhibitor and histamine blocker therapy, which is commonly done.
It ain't as simple as it sounds sometimes. Raj Narayani, you're a great, great, great teacher, and it's an honor having you on the show to help us know how to calm down the fire of heartburn. You've been great. You'll have to come back with us again.
Will do. Thank you so much, Bob.
And remember, you've got to be exercising. It will relax everything and it'll help GERD. You've got to be getting 7.5 hours of sleep. When you sleep well, the reflex usually goes away. What you eat is how you are, so be sure you're eating properly, not too much food, and most of all, what is it we like? Well, we've been laughing the whole show, having a good time, socializing with each other. That's got to be a part of our healthy lifestyle. It's that laughter. The more you laugh, the healthier you'll be.